We'll have discussion in the end. For the next talk, we did a survey in MCOA, and we found that about 70% of doctors, even now, are still using the ultrasound biometer and maybe getting fairly good results with it. To talk on that, we have Dr. AADITHREYA VARMAN. He is a trainer and medical director at Umai Clinic. He obtained the prestigious CP Gupta Award at TNOA, youngster with a voracious appetite for publication and research. He will be talking to us on the role of ultrasound biometry in today's practice.
Hello and good morning. So today I'm here to talk about ultrasound biometry and its role in refractive cataract surgery practice today. So as we all know, accurate biometry is a cornerstone of any refractive cataract surgery. We have to absolutely nail all our biometric parameters to give the patient a good emmetropic result. So what are the main parameters we look at? We look at the axial length, AC depth, and lens thickness that any formula needs to give you an accurate biometry. The ultrasound biometer uses the ultrasonic waves to go ahead and give you the correct measurement of the axial length. So to understand it better, let's go back to the basics. So the ultrasound probe is a piezoelectric crystal that vibrates around 10 megahertz. It projects a thin beam of sound. This beam is either reflected, absorbed, or refracted. The beams which are going through and getting absorbed, part of them are also reflected back as echoes. These echoes will be detected by the transducer as waves or electric waves. And the more dissimilar the substance in the ocular anatomy, the stronger the reflection or the echo. So the measurement in the optical or ultrasonic biometers, usually from the anterior corneal surface to the internal limiting membrane. The accuracy of the ultrasonic biometers is about 0.1 mm between every reading. So a good ultrasonic biometric measurement has to give you these 5 waves. The first one will be when the probe meets the cornea. The second wave is from the anterior part of the lens capsule. The third wave is from the posterior pole. Then the fourth wave is from the retina, and the following waves are from the sclera and the orbital fat. So this is what an ideal A scan should look like. It should have good hyperechoic waves with the first wave coming from the probe, as I mentioned, and a good spike from the anterior lens capsule, and another good spike from the posterior lens capsule, and following the retinal spike, and then the scleral spikes. There should be no echoes in the vitreous cavity space. So there are 2 ways to go about your ultrasonic biometric measurements. One will be from the contact or applanation method, and the other is from the immersion method. So the contact method uses the ultrasound probe, which is directly placed on the anesthetized cornea. This is the most commonly used method in most places, but this has the drawback of indenting the cornea, which will give you a fairly shorter reading than the true measurement of the axial length. Whereas in an immersion scan, we use the shell known as a scleral shell or a Prager shell. We use a coupling fluid in front of the cornea, and once the shell is placed on top of the cornea, it is filled with BSS. And then you can use your probe to immerse the probe into the shell and get your reading. So this negates the effect of the corneal compression and gives you a more accurate measurement of the axial length and leading to more reproducible results. So this is your typical immersion A scan. You will see here, since the probe does not come in contact with the cornea, you have an extra wave coming from the probe, and then you can see a double spike coming from the anterior cornea and the posterior cornea. And following which you see the spike from the anterior lens and then the posterior lens. Then you see a line with the vitreous cavity, and then you have the spike from the retina and sclera. So immersion, as I said, works better and gives you more accurate results compared to applanation. But the drawbacks are it could be time consuming and messy, and you have to have the patient supine during the procedure. And after a single immersion biometry measurement, you do have chances of infection. There are studies which shows that organisms were grown from the shell and tubing of the immersion instruments. So what we do to counteract this is, after doing our measurements, we have to soak the immersion tube and the probe in hydrogen peroxide and alcohol for at least 5 minutes. And it should be allowed to completely dry and should be flushed with balanced salt solution. So what are the cornerstones of an accurate A-scan measurement? One, the machine should be correctly calibrated. We should ensure that the patient is in the correct position. The probe must be absolutely perpendicular to the iris plane, and there should be minimal corneal compression. It would be ideal to do the A-scan with the patient in the lying down position and never the patient sitting down. So this is an example of incorrect positioning. As we see here, the patient is lying down with the head at an angle. This is bound to give you errors because the angle of incidence at which you place your A scan can be inappropriate. You will not be going at the anatomical visual axis. So this is the example of an correct head positioning. As we see here, the head is absolutely flat. Iris will be parallel to the floor. And now when you go ahead and place your probe perpendicular to the iris, you will get a good axial length measurement. So as I said earlier, the idea is to avoid corneal compression. The iris has to be parallel to the floor with the probe perpendicular to the plane. When the corneal beam is parallel to the visual axis, the returning echoes received back to the probe will result in a high amplitude spikes is what we like to see in a good A-scan measurement. So fixation can be helped by giving the patient a target to fix at. You can use a patient's hand, or you can use an overhead fixation target, or you can simply ask the patient to look at the fixation light in the A-scan probe. So here is an example of a good A-scan measurement where the patient's head is parallel to the floor and the iris is parallel, and the patient is looking up at his own thumb to fixate, and the probe is being held by the wire to avoid the chance of any corneal compression effect. So this is the fixation light that the patient can be asked to look at to go ahead and enhance the patient cooperation. It is also ideal to wet the probe before going ahead with any A-scan measurement, because measuring on a dry cornea can also give rise to a fallacy in the results. Also, so here is an example of an corneal compression happening, because when you hold the probe with your fingers, you do have a chance of indenting the cornea unknowingly. Whereas if you hold it by the wire, the chances of corneal indentation is greatly reduced, and you give a more accurate axial length measurement with the A-scan. So again, this is a very typical A-scan, which is a good measurement. We see the high amplitude spikes, and all the 5 spikes are very well seen here. And make at least 2 measurements. Multiple measurements are more ideal. And a 0.5 mm measurement, the variation between 2 readings is acceptable, but one should aim for at least a 0.2 mm variation between multiple readings. Yeah. So when you're not getting the correct waves in cases of a dense cataract or any other opacity, it would be ideal to increase the gain. So the height of the echoes will be adequate in a denser cataract. A decrease in gain is required when you have other artifacts in the interface of the vitreous, such as in silicone eyes or any other vitreous pathology. But one should be aware that a high gain can give rise to a shorter axial length reading, whereas a low gain can give rise to a longer reading. These are the sound velocities that have to be modified for different cases. For aphakia, make sure that you are selecting the aphakia mode, and for silicone oil, do select silicone oil mode. Another important thing when you're doing an immersion biometric scan is to select the immersion mode on a biometer, and also take multiple readings, and every reading check the waveform in every A-scan. Choose the best and the most consistent one. Do not take an average of all the readings. If you're taking 5 readings and if 2 readings are way out of bounds, it will be better to eliminate those 2 readings which are out of bounds and take an average of the 3 readings which are all similar to each other with the same axial length. So here is an example of multiple readings being done. So as we see here, on all the readings, the axial lengths are quite similar to each other. It would be prudent to take the first scan here, as this scan has the best waves. So this is the ideal scan with which the waves are all of high amplitude. This is the scan which we would take in all our axial length readings. So, and ensure that all your other steps are on point, or otherwise you can have a stacking effect and give you an erroneously wrong formula. Make sure that your K values are all consistent, and make sure that your A constants are also on point. Otherwise, the IOL power that you will have between 2 readings can be grossly wrong. So here are the pearls. Calibrate the instrument, use immersion method, make sure the iris is parallel to the probe. The probe should be perpendicular to the iris plane. Ensure patient fixation, check all the waveforms, and hold the probe with the wire while doing the contact method, and do not take an average of all the readings. So the drawbacks are it measures from the anterior to the posterior pole. So it only measures the anatomic axial length and not the optical or visual axial length. It also only measures up to the internal limiting membrane. It does miss out 200 microns of the retinal thickness. So you can have an error here. So the causes of an erroneously short measurement can be corneal indentation, low sound velocity, too high enough of a gain, or a malalignment of the probe. And erroneously long measurement can happen when there's a rapid sound velocity, too low of a gain, or a posterior staphyloma. So the potential of error is more in a shorter eye, but is more forgiving in a longer eye. So can A scan give you precise results? There are multiple studies and publications out there that are proving that A scan is as good as an optical biometer when done correctly, when you take all the appropriate steps as mentioned above. You can give a good result with a very low post-operative residual outcome, as long as you follow all these preceding measurements. And it should not really deter you from going ahead and giving your patient a premium experience and with a premium IOL result. So an A scan with a good technical skills can give you good results at the end of the day. Thank you.
So much, Adit, for a wonderful presentation. You've covered everything on A scan.